I'm Dr. Tan Su Yong from the Department of Pathology, National University of Singapore. In this talk, I will discuss the pathology of reactive lymphadenopathies and their differential diagnoses.
First, let us do a quick revision of the structure of the lymph node. The outermost part of the lymph node is the cortex, which features many lymphoid follicles with prominent germinal centers. The lymphoid follicles comprise mainly B cells. The subcapsular sinus is patent, but is normally inconspicuous, containing a small number of histiocytes. Deep to the cortex is the paracortex, where the lymphocytes are mainly T cells. The paracortex and the interfollicular region between the lymphoid follicles comprise the T cell zones. Higher magnification of the T cell zone in the paracortex features prominent high endothelial venules and a heterogeneous population of T cells of varying sizes, along with small numbers of plasma cells, eosinophils, and histiocytes. Deeper to the paracortex, close to the hilum of the lymph node, is the medulla, where the stroma is more fibrous with blood vessels and lymphatic vessels within, but the lymphocytes are sparse here. At higher magnification, the large germinal centers can be divided into a dark zone composed of mainly centroblasts, and where there are many macrophages containing apoptotic bodies, as well as a light zone comprising mainly centrocytes. Centroblasts are germinal center B cells with higher nuclear cytoplasmic ratio and prominent nucleoli, whereas centrocytes are smaller with lower nuclear cytoplasmic ratio and they lack conspicuous nucleoli. The mantle zone is thinner near the dark zone and thicker adjacent to the light zone. The mantle zone comprises small lymphocytes with slightly irregular nuclear contours, dark condensed chromatin, and no obvious nucleoli.
We can classify reactive lymphadenopathies based on etiology into infective causes such as EBV, CMV, tuberculosis, and so on, and non-infective causes such as Kikuchi lymphadenitis, lupus lymphadenitis, and Castleman's disease, for example. Alternatively, we can also classify reactive lymphadenopathies based on the predominant morphological pattern into follicular, paracortical, and interfollicular patterns. There is also sinus hyperplasia, granulomatous, and necrotizing types, and some diseases display a prominent fibrotic appearance, whilst others may show a combination of morphological patterns. First, let us consider reactive lymphadenopathies with a follicular pattern. Follicular hyperplasia is characterized by an increase in the number and size of lymphoid follicles. The node architecture is preserved, just that the follicles are larger and more numerous. The main differential diagnosis in this case is follicular lymphoma. The difference from follicular hyperplasia is that the mantle zones are thinned or attenuated in follicular lymphoma, and the germinal centers may lack macrophages containing apoptotic bodies. Most cases of follicular lymphoma possess the 14/18 translocation, resulting in overexpression of BCL2 in the germinal center B cells.
Although 15 to 20% of follicular lymphomas stain negative for BCL2.
CD10 positive B cells are normally confined to the germinal center in follicular hyperplasia,
but are seen infiltrating the interfollicular zone between the lymphoid follicles in the case of follicular lymphoma.
The proliferation fraction based on Ki67 staining is lower than that in reactive follicular hyperplasia, and there is loss of zonal polarity, showing a uniform population of proliferating cells. On the left, you can see follicular hyperplasia featuring large follicles with hyperplastic germinal centers comprising a mixture of centroblasts and centrocytes with scattered macrophages. In contrast, we do not see a distinct mantle zone in follicular lymphoma on the right, which comprises large follicles composed of a uniform population of centrocytes. hardly any apoptotic bodies or macrophages can be seen. Germinal center B cells stain positive for BCL6 in both follicular hyperplasia and follicular lymphoma, but you can appreciate the aberrant overexpression of BCL2 in the germinal centers of follicular lymphoma on the right, whereas normal germinal centers in follicular hyperplasia stain negative for BCL2. The germinal center marker CD10 is expressed in both follicular hyperplasia and follicular lymphoma, but notice that staining for CD10 is stronger and more uniform in the neoplastic follicles of follicular lymphoma. The proliferation fraction, as highlighted by Ki67 staining, is higher in reactive follicular hyperplasia with preservation of zonal polarity. You can see the higher proliferation fraction in the dark zone of the germinal centers and lower in the light zone. That is zonal polarity. In contrast, in the follicular lymphoma, the proliferation fraction is actually lower and there is no preservation of zonal polarity when stained for Ki67.
However, it must be remembered that some cases of high-grade follicular lymphoma will show higher proliferation fractions, although there will be loss of the zonal polarity. Another differential diagnosis that we must distinguish from reactive follicles or reactive follicular hyperplasia is the pattern 1 of angioimmunoblastic T-cell lymphoma or AITL. AITL is a T-cell lymphoma arising from follicular helper T cells, and it develops in stages. It starts off as enlarged follicles in pattern 1, followed by depleted or regressed follicles in pattern 2, and finally, in pattern 3, all the follicles disappear and the T-cell lymphoma presents a diffuse pattern. As you can see, pattern 1 of AITL can resemble reactive follicular hyperplasia. So how do we differentiate the early pattern 1 of AITL from reactive follicular hyperplasia? First, AITL tends to occur in older patients, whereas reactive follicular hyperplasia is more common in children and adolescents. The neoplastic follicles feature fewer CD10 positive germinal center cells, and instead there are more CD10 positive lymphocytes in the interfollicular zone. The T-cell population may downregulate pan-T markers such as CD2, CD3, CD5, and CD7, whilst CD4 positive, PD1 positive intrafollicular T cells move out into the interfollicular zone, which displays a higher proliferation fraction. Increased numbers of EBV positive B cells are seen, and PCR will show clonal rearrangement of T-cell receptor genes. Staining for CD10 is strong in a reactive follicle, but is weak or lost in AITL pattern 1 and 2. In follicular hyperplasia, PD1 stains intrafollicular T cells inside the germinal center. In pattern 1 AITL, PD1 positive T cells are seen just outside the germinal center and in the interfollicular zone. Next, we look at progressive transformation of germinal centers or PTGC. This is a reactive phenomenon seen in follicular hyperplasia as an isolated event. As such, it is not a diagnosis by itself, but is used as a descriptive term to distinguish it from a lymphoma. PTGC tends to occur in children and young adults when follicular hyperplasia is common. It is not associated with nodular lymphocyte predominant Hodgkin lymphoma, but must be distinguished from it. Unlike nodular lymphocyte predominant Hodgkin lymphoma, PTGC is a reactive phenomenon and is completely benign and self-limiting. In PTGC, we see an expanded lymphoid follicle due to increased mental zone B cells that infiltrate into the germinal centers. This results in 1 or 2 expanded follicles that are at least 3 times the size of adjacent normal-looking follicles. We see occasional follicles that are expanded, featuring hyperplastic mental zone B cells that infiltrate into the germinal centers. Over time, the mental zone is no longer distinct, and the centroblasts of the germinal centers are surrounded by small mental zone B cells. In this view, the lymphoid follicle appears as a nodule of mainly small lymphocytes without a clear mental zone and distinct germinal centers. IGD highlights the numerous mental cells that have infiltrated the germinal centers. CD21 highlights the underlying expanded follicular dendritic meshworks, and BCL6 decorates the strongly stained centroblasts as well as the weakly stained mental zone B cells that have infiltrated the germinal centers. Unlike nodular lymphocyte predominant Hodgkin lymphoma, PTGC is a focal phenomenon and does not involve the entire lymph node. Clusters of epithelioid histiocytes and typical LNH cells seen in nodular lymphocyte predominant Hodgkin lymphoma are absent in PTGC. The large cells seen in PTGC may be mistaken for the neoplastic LNH cells of nodular lymphocyte predominant Hodgkin lymphoma. But the large cells in PTGC are actually centroblasts that are not seen outside the nodules. They tend not to be rosetted by CD57 positive T cells, and they are CD10 positive, whereas LNH cells are CD10 negative, although both of them will express BCL6. This is an example of nodular lymphocyte predominant Hodgkin lymphoma, showing scattered large LNH cells that are surrounded by small lymphocytes. The large cells lack CD10 expression, although they are positive for LMO2 and BCL6. Next, we look at HIV-associated lymphadenopathy. HIV infection may present with different pathological features. It may present as a reactive lymphoid hyperplasia, as Castleman's disease, usually of the plasma cell variant type. Opportunistic infections are common in HIV, or an HIV-associated lymphoma such as Burkitt lymphoma or diffuse large B-cell lymphoma may be seen. Or it may present with an intermediate phase as HIV-associated polymorphic lymphoproliferative disorder. The typical feature of HIV lymphadenopathy is extremely florid follicular hyperplasia with bizarre germinal centers. There is also follicular lysis due to disruption of the underlying follicular dendritic meshworks. This is not a unique feature of HIV lymphadenopathy and may be seen quite commonly in cases of florid follicular hyperplasia. On CD21 staining, you may see the follicular dendritic cell meshworks have been broken up into little pockets floating in a sea of small lymphocytes. At low magnification, notice the large follicles with the hyperplastic and bizarre-looking germinal centers. The enlarged germinal centers feature scattered macrophages, giving a starry sky appearance. The interfollicular region shows an increase in the number of plasma cells, and CD21 staining highlights the enlarged and distorted follicular dendritic cell meshworks. In situ hybridization shows polytypic expression of immunoglobulin light chains, so the plasma cells are reactive in character. Here we see an enlarged germinal center with a nodule of small lymphocytes breaking up the germinal center. Strong expression of CD79A and IgD identifies the nodule of small B cells as mental zone B cells that are also BCL2 positive. Here we see the hyperplastic germinal center, which is BCL6 positive, with a high proliferation fraction, being broken up by a nodule of mental zone B cells, which are BCL6 negative, showing a low proliferation fraction. CD21 identifies the part of the germinal center that is infiltrated by mental zone B cells, showing pockets of follicular dendritic cells that are suspended in a pool of small mental zone cells. Only small residual germinal center B cells are seen,
with CD10 staining, and CD21 highlights the residual regressed follicular dendritic meshworks that are undergoing follicular lysis. Numerous CD138 positive plasma cells are seen in the interfollicular region.
HIV is known to infect follicular dendritic cells, thereby resulting in the destruction of the underlying follicular dendritic meshworks. This is also known as follicular lysis. Immunostaining for HIV viral protein P24 will confirm the diagnosis. With progression, the lymph node undergoes involution so that they may resemble the regressed follicles of Castleman's disease. Another feature of HIV infection is the presence of plasmacytosis. Increased numbers of plasma cells may be parts of HIV lymphadenopathy or as multicentric plasma cell Castleman's disease, a complication of HIV and associated with HHV-8 and EBV co-infection. In this example, we see a hyperplastic lymphoid follicle, an expanded interfollicular zone containing many plasma cells. There are also aggregates of histiocytes and scattered multinucleated giant cells. At higher magnification, we see the increased numbers of plasma cells and scattered multinucleated giant cells that are typical of HIV lymphadenopathy. CD20 decorates only small regressed follicles, but numerous CD79A positive, CD20 negative B cells are seen. These are in keeping with plasmacytic differentiation. Only small residual germinal center B cells are seen with CD10 staining, and CD21 likewise highlights residual regressed follicular dendritic meshworks that are undergoing follicular lysis. Numerous CD138 positive plasma cells are seen in the interfollicular region. In situ hybridization shows polytypic immunoglobulin light chain expression in keeping with reactive plasmacytosis, but hardly any IgG4 positive plasma cells are seen, thereby excluding IgG4 related disease. The lack of EBV and HHV-8 expression in this case rules against HHV-8 associated Castleman's disease. Next, we shall examine reactive lymphadenopathies that are characterized by paracortical and interfollicular expansion. This group of conditions is dominated by viral infections, the majority of which produce marked expansion of the paracortex with many activated blast cells seen. At times, we may see atypical lymphocytes and in particular, Reed-Sternberg light cells may be seen, particularly in cases of EBV infections. First, let us consider infectious mononucleosis. The lymph node in infectious mononucleosis is enlarged and soft, but are not matted together. The capsule remains thin, and the cut surface appears uniform and pink with yellowish foci of necrosis. The histology shows partial effacement of the nodal architecture by a paracortical infiltrate that contains numerous immunoblasts and large activated lymphocytes with prominent nucleoli. They are accompanied by variable numbers of eosinophils and plasma cells. An important feature to note is that there is a spectrum of lymphoid cells ranging from small lymphocytes with dark condensed chromatin, larger activated lymphocytes with more open chromatin, and prominent nucleoli, including cells that look like immunoblasts and Reed-Sternberg-like cells. Plasmablasts and mature plasma cells are also seen. The spectrum of lymphoid cells showing varying degrees of maturation is important to distinguish infectious mononucleosis from a large cell lymphoma. There may be varying degrees of follicular hyperplasia and sinus histiocytosis as well. At low power, we can see foci of necrosis and loss of normal immunoarchitecture. The lymphoid follicles are not easily discernible, and instead, the paracortex and interfollicular zones are expanded. We can see a proliferation of lymphoid cells of varying sizes between the high endothelial venules. At higher magnification, we can see small lymphocytes with condensed chromatin, larger activated lymphoid cells with more open chromatin and prominent nucleoli, including immunoblasts and mature plasma cells. Large cells with prominent nucleoli can be numerous, but once again, notice the spectrum of small lymphocytes, larger lymphocytes with more open chromatin, and immunoblasts. Here we see an example of infectious mononucleosis showing a hyperplastic follicle and expansion of interfollicular zone with a mottled appearance due to scattered macrophages and large immunoblasts. Aggregates of monocytoid cells are seen in this example, and scattered Reed-Sternberg-like cells can also be identified. Once again, we can appreciate the spectrum of small lymphocytes, larger lymphocytes with open chromatin, Reed-Sternberg-like cells, and plasma cells. Here is another Reed-Sternberg-like cell in infectious mononucleosis. The lesson here is that just because you see cells that look like Reed-Sternberg cells does not make it Hodgkin lymphoma. EBV infection can transform a B cell to adopt the morphology of Reed-Sternberg cell. We only call it a Hodgkin Reed-Sternberg cell and diagnose classical Hodgkin lymphoma when there is an appropriate inflammatory background of reactive lymphocytes, eosinophils, neutrophils, histiocytes, and plasma cells. We will discuss the pathology of Hodgkin lymphoma in a later session. We may even find mummified large cells that may suggest classical Hodgkin lymphoma. Infectious mononucleosis indeed is often misdiagnosed as large cell lymphoma or Hodgkin lymphoma. The immunohistochemistry is helpful in that it shows a mixture of B and T cells, often with a predominance of medium and large CD3 positive T cells, and that may help distinguish infectious mononucleosis from a large B-cell lymphoma. Evidence of viral infections may be detected by immunostaining for LMP1 or CMV. The large Reed-Sternberg-like cells are CD30 positive, but are usually negative for CD15 and EMA. Here is an example of infectious mononucleosis. The CD20 positive lymphoid follicles are small and regressed compared to the interfollicular expansion by CD3 positive T cells. There is also a focus of necrosis taking up non-specific staining. There are a lot of CD79A positive but CD20 negative cells in the interfollicular region. These are plasma cells that have downregulated CD20. The proliferation fraction is relatively high, and if you double stain, you will find that both T and B cells are proliferating. CD20 highlights small lymphoid follicles, but notice that in the interfollicular region, there are scattered large CD20 positive lymphocytes. Scattered large cells stain positive for CD5, indicating T cell lineage as well. CD21 shows regressed follicles, and a few residual lymphoid follicles can be identified by CD10. In situ hybridization shows EBA expression in many lymphocytes and involving both small and large lymphocytes. The large activated lymphocytes in infectious mononucleosis, including the Reed-Sternberg-like cells, are CD30 positive. In situ hybridization shows many EBA positive lymphocytes involving both small and large cells. Now this is very different from EBV positive Hodgkin lymphoma, where only the large neoplastic lymphocytes are EBA positive. Next, consider CMV lymphadenitis. The presentation is quite similar to infectious mononucleosis, except that this occurs in immunocompromised patients, and you may see CMV cytopathic effects, like this cell with nuclear and cytoplasmic inclusions. CMV infected cells can be easily identified by staining for CMV. This case looks quite unremarkable, with both follicular hyperplasia and expansion of the interfollicular zone together with sinus histiocytosis. A heterogeneous population of lymphocytes is seen in the interfollicular zone, whereas germinal centers appear reactive with numerous macrophages and apoptotic cells. However, scattered CMV-positive lymphocytes are noted. Dermatopathic lymphadenopathy is a common condition, and presents as enlargement of lymph nodes that drain an area with a skin rash. In the interfollicular zone, we see pale regions featuring aggregates of Langerhans dendritic cells, and they show elongated, twisted, and folded nuclei with pale cytoplasm as well as pigment-laden melanophages. The immunoarchitecture is preserved with CD20 positive, CD79A positive B cell follicles and CD3 positive interfollicular zones. The proliferation fraction is high in the reactive germinal centers with preservation of zonal polarity. On the other hand, staining for CD1A highlights aggregates of Langerhans dendritic cells in the interfollicular region. Langerhans dendritic cells, or sometimes referred to as Langerhans histiocytes, they are dendritic cells that present antigens from the skin to the draining lymph node. CD68, on the other hand, highlights the normal macrophages in the germinal centers. Next, we look at Castleman's disease. Castleman's disease is a benign lymphoproliferative disorder of unknown etiology, but with characteristic histological features. They can be divided into unicentric cases presenting as a solitary mass and multicentric cases that can affect multiple organs. Unicentric Castleman's disease is usually benign and self-limiting. Microscopic examination may show either hyaline vascular or plasma cell variants, with the latter associated with more systemic symptoms. The multicentric form of the disease is more commonly associated with HIV and HHV-8 infections. Patients are more likely to present with systemic symptoms and signs such as fever, night sweats, cachexia, lymphadenopathy, splenomegaly, cytopenia, and hypoalbuminemia. It may also be associated with the POEMS syndrome, which is a complex of polyneuropathy, organomegaly, endocrinopathy, monoclonal gammopathy, and skin changes. Many of these symptoms are related to abnormal immunoglobulin production, and the histological subtype is usually the plasma cell variant. The disease usually affects the lymph nodes, but extranodal sites can also be involved. The etiology is unknown, but it is likely an inflammatory response to antigenic stimulation. In the case of the hyaline vascular type of Castleman's disease, elevated VEGF has been linked to the proliferation of blood vessels, whereas IL-6 production is associated with the plasma cell variants of the disease. IL-6 production could be the result of viral infections such as HHV-8. On the other hand, it could be idiopathic. Let us now examine the hyaline vascular type of Castleman's disease. The lymph node shows multiple follicles, but when you examine the lymphoid follicles carefully, you will notice that the follicles are composed of mainly small mantle zone lymphocytes, whereas the germinal centers are very small or are completely absent. Notice the blood vessels that penetrate into the germinal centers, so-called transfixing blood vessels, giving rise to a lollipop appearance. Also note the concentric layering of mantle zone cells, giving an onion skin appearance. The interfollicular region features prominent vascular proliferation with hyaline collagenous fibers. This follicle shows completely regressed germinal centers. No centroblasts and centrocytes are seen, but instead you see concentric layers of mantle zone cells typical of hyaline vascular type of Castleman's disease. Whilst proliferation of blood vessels and fibroblasts are seen in Castleman's disease, an exaggerated form of stromal response is seen in the stromal-rich variants. The lymphoid follicles are regressed, with no germinal center seen, and lymphoid follicles comprise only mantle zone cells. The interfollicular zone is expanded and features a proliferation of blood vessels and fibroblasts. There is still a heterogeneous population of lymphocytes in the interfollicular region, but notice that the lymphocytes are more scanty and replaced by increased blood vessels. There is also increased fibroblasts and collagen, and hence the name stroma-rich variant of Castleman's disease. We now have a short 3-minute break. Next, we move to the group of IgG4-related disease. This is an adult lady who presented with bilateral lacrimal gland enlargement for a year. Biopsy of the cervical lymph node shows scattered follicles with preserved germinal centers. The interfollicular region contains numerous plasma cells in a fibrotic stroma. Immunohistochemistry shows normal appearing CD20 positive lymphoid follicles with intact IgD positive mantle zones enclosing reactive germinal centers, as well as slightly expanded interfollicular T cell zones containing CD3 positive T cells and scattered CD30 positive large cells. Increased interfollicular plasma cells are seen that display polytypic immunoglobulin light chain expression. Plasma cells stain strongly for IgG4, being more than 100 IgG4 positive plasma cells per high power field, and double staining for IgG4 and IgG shows more than 50% of IgG4 positive cells. IgG4 related disease is an autoimmune disease presenting in adults and is characterized by elevated serum IgG4, sclerosing lesions in various organs including the lacrimal gland, salivary gland, pancreas, thyroid, lymph node, and serous membranes as sclerosing pruritus, pericarditis, and retroperitoneal fibrosis. An important characteristic is steroid sensitivity. The histology shows a dense lymphoplasmacytic infiltrate associated with storiform fibrosis and obliterative phlebitis. However, these features are often absent in IgG4 lymphadenopathy apart from an increased number of plasma cells. As the disease may present in multiple organs, IgG4-related disease has been called by many names in the past, including Reiter's thyroiditis and idiopathic retroperitoneal fibrosis. It is characterized by an increase in IgG4 expressing plasma cells. But how many IgG4 positive plasma cells is enough to make the diagnosis? The cutoff criteria may vary according to the organs involved, from more than 10 IgG4 positive cells per high power field in the meninges to as high as 100 in the lymph node and even 200 per high power field in the skin. Lower numbers of IgG4 positive cells do not exclude the diagnosis, but the diagnostic certainty will drop. Sinus histiocytosis refers to an increase in the number of histiocytes within the nodal sinuses. This is a common reactive phenomenon in a variety of conditions, such as a response to malignancy. So sinus histiocytosis is commonly seen in the axillary lymph node of patients with breast cancer. Let us consider a condition characterized by very prominent sinus histiocytosis known as Rosai-Dorfman disease. This is known in the past as sinus histiocytosis with massive lymphadenopathy. This condition presents in children and adolescents as bilateral large painless cervical lymph nodes. It is often associated with extranodal involvements in the skin, lung, gut, bone, or brain. There are often systemic symptoms such as fever, anemia, raised leukocyte counts, and polyclonal hypergammaglobulinemia. The clinical course is generally benign, but may be long and relapsing. There is no optimal treatment currently, and immunosuppression may even cause death, but this is rare. On microscopic examination, the nodal sinuses are distended by large numbers of macrophages. These macrophages are larger than usual and they contain many morphologically identifiable lymphocytes and other inflammatory cells in its cytoplasm. This phenomenon is known as emperipolesis. With chronicity, fibrosis may be seen. In this case, you can see pale islands comprising sheets of large macrophages with numerous intracytoplasmic neutrophils, lymphocytes, and plasma cells. Here is a higher magnification showing the large macrophages with numerous neutrophils, lymphocytes, and plasma cells within the cytoplasm. By immunohistochemistry, these macrophages stain positive for CD68 and S100. Next, we move to the group of granulomatous lymphadenitis. First, we consider tuberculous lymphadenitis. Typically, we see large geographic areas of caseation-type necrosis, which is seen histologically as amorphous eosinophilic necrotic debris that are surrounded by aggregates of epithelioid histiocytes, Langhans-type multinucleated giant cells, lymphocytes, and plasma cells. There is central caseation-type necrosis surrounded by aggregates of histiocytes and Langhans giant cells, chronic inflammatory cells including lymphocytes and plasma cells. Acifas bacilli may be few and scanty. They are not essential for diagnosis, and even when absent, clinicians should be advised that tuberculosis is not excluded and is in fact rather likely in this region. Next, we consider sarcoidosis, a non-caseating granulomatous disease. This is a non-infective granulomatous disease that involves multi-organ systems. It has a global distribution, being more common in blacks than whites, more common in Indians than Chinese in the Singapore population. Apart from the lung, which is a common site of involvement, other sites include lymph nodes, eyes, skin, and liver, but any organ can be affected. The skin often displays erythema nodosum. Production of PTH-related protein in this condition may explain hypercalcemia that is often associated. Microscopic examination shows granulomatous inflammation, but the granulomas are so-called naked granulomas, where the aggregates of epithelioid histiocytes are associated with scanty lymphocytes. Necrosis is absent or limited, unlike tuberculosis, although necrotizing sarcoidosis does exist. Crystalline structures such as Schaumann bodies, asteroid bodies, and calcium oxalic crystals may be seen, but they are not required for the diagnosis. There is effacement of nodal architecture in this lymph node, showing numerous granulomas comprising discrete rounded aggregates of epithelioid histiocytes and multinucleated giant cells. There are few lymphocytes and no necrosis is seen. Higher magnification of the granuloma showing aggregates of epithelioid histiocytes with few lymphocytes. Immunostaining for Ki67 highlights a normal reactive follicle in the residual lymph node. Next, we consider cat scratch disease. This is an infective, necrotizing granulomatous disease. Cat scratch disease is caused by a bacterial infection with Bottonella hansellae. It is often transmitted to humans by scratches from cats and kittens, hence the name cat scratch disease. The incubation period is about 1 or 2 weeks, and it presents with nodal enlargement in the draining lymph node, often associated with fever. The disease is self-limiting and will resolve over weeks. The diagnosis can be confirmed by serology. On microscopic examination, there are large suppurative granulomas or stylates microabscesses that contain numerous neutrophils which are surrounded by histiocytes. The typical necrotizing granuloma in cat scratch disease features a central focus of necrosis containing neutrophils and are surrounded by CD68 positive histiocytes. The next condition we will consider is Yersinia lymphadenitis. This is another example of necrotizing granulomatous disease. On microscopic examination, we can see multiple microabscesses featuring collections of neutrophils and necrosis that are surrounded by aggregates of epithelioid histiocytes. higher magnification showing central necrotizing foci with numerous neutrophils and peripheral aggregates of histiocytes. Next, we consider silicone lymphadenopathy. This is a form of foreign body granulomatous lymphadenitis. At low power, lymph node architecture is altered, showing large empty spaces with residual nodal tissue containing remnant lymphoid follicles are seen. The lymph node is replaced by aggregates of foam cells with bubbly cytoplasmic vacuolation. Occasional aggregates of epithelioid histiocytes are seen, and on careful examination, you may see refractile material focally. The next condition we will look at is an infective but non-necrotizing granulomatous lymphadenitis, namely Toxoplasma lymphadenitis. This is also known as Pyrynga-Kuchinka lymphadenitis and is caused by an obligate intracellular parasite called Toxoplasma gondii. It is transmitted by cat feces, and clinically it can be asymptomatic or present with lymphadenopathy. Perhaps more worrying is that an acute infection in pregnant women can damage the developing fetus. On microscopic examination, there is a typical triad of histological findings comprising 1. Reactive follicular hyperplasia, 2. Monocytoid B-cell hyperplasia, and 3. Non-necrotizing granulomas that may encroach upon and even infiltrate the germinal centers. Paracortical expansion is not as prominent as with infectious mononucleosis. This case shows scattered granulomas in the paracortex of the lymph node, which also shows reactive follicular hyperplasia. Here is a high magnification view of the granuloma. Here we see monocytoid hyperplasia featuring sheets of monocytoid B cells with round and condensed chromatin, as well as ample clear cytoplasm separating the nuclei from adjacent cells. In this example, we see reactive follicular hyperplasia showing a hyperplastic germinal center and numerous granulomas both in the interfollicular region but also infiltrating the germinal center. This is a high magnification view of the granuloma, and there are also sheets of monocytoid cells. We now move to the group of reactive lymphadenopathies that show a necrotizing pattern, excluding necrotizing granulomatous inflammation, which I have covered earlier. First, let us consider Kikuchi lymphadenitis, which is also known as necrotizing histiocytic lymphadenitis. This is a non-infective necrotizing lymphadenitis that is more commonly seen in Asia and usually affecting young adults with a slight female predominance. The etiology is unknown, but there is prominent apoptosis of CD8 positive T cells along with elevated serum levels of cytokines. The usual presentation is as a painless enlarged cervical lymph node. It may be associated with systemic symptoms such as fever, chills, myalgia, sore throat, and skin rash. The clinical course is benign with spontaneous resolution, and rarely does the disease relapse. Hepatosplenomegaly is uncommon. Now, if there is cutaneous involvement as well, one must be careful to consider the differential diagnosis of SLE, because lupus lymphadenitis may display very similar histological features, except for the presence of fibrinoid necrosis, but that may not be seen all the time. So lupus lymphadenitis must always be considered whenever we make a diagnosis of Kikuchi lymphadenitis. The nodal architecture is partially maintained, and there may be residual lymphoid follicles that appear normal. The paracortical region contains necrotizing areas with eosinophilic debris and numerous nuclear fragments or nuclear dust surrounded by aggregates of pale staining histiocytes. The aggregates of histiocytes are seen to engulf apoptotic debris, and their nuclei become compressed and appear crescentic. In addition, you will see scattered apoptotic cells and nuclear debris. The necrotizing lesions in Kikuchi lymphadenitis are due to apoptosis rather than necrosis, and instead of neutrophils, we see proliferation of histiocytes. In fact, histiocytic proliferation may be the only feature with very little or no necrotizing foci at all. In addition to histiocytes, there may be small lymphocytes, activated lymphocytes, and plasma cells, but no neutrophils or eosinophils are seen. There may be thrombosed blood vessels, but in addition, there are nests and aggregates of plasmacytic dendritic cells as well as immunoblasts. These are large cells and so may be mistaken for a large cell lymphoma. At low power, we see pale necrotizing areas within the lymph node. At higher magnification, we see numerous nucleodasts, apoptotic cells, and macrophages with crescentic nuclei. High magnification shows macrophages with crescentic nuclei and cytoplasm that is filled with nuclear debris. Notice that you do not see any neutrophils or eosinophils. Immunohistochemistry shows small regressed B-cell follicles and expanded interfollicular and paracortical areas featuring numerous CD3 positive T cells. But you may also see a number of cells in between that stain negative for CD3. These are the histiocytes and plasmacytic dendritic cells, which are increased in numbers in this condition. Staining for Ki67 shows a fairly high proliferation fraction in cells adjacent to a necrotizing focus. Many of these proliferating cells are plasmacytic dendritic cells. CD30 decorates scattered activated lymphocytes. Although there are hardly any neutrophils seen, and the main histological feature in this condition is proliferation of histiocytes, these histiocytes are unusual in that they express myeloperoxidase, which is an enzyme that is normally expressed in neutrophils. The other marker that is useful in this condition is CD123, which highlights the proliferation of plasmacytic dendritic cells. These cells tend to proliferate and show a high Ki67 proliferation fraction, particularly prominent in the early phase of the disease. Finally, let us look at reactive lymphadenopathies that present a particularly fibrotic pattern. IgG4-related lymphadenopathy certainly results in fibrosis, and we have already discussed that earlier. Now, we want to look at syphilitic lymphadenitis. Syphilis is rarely seen in developed nations today. To recapitulate, primary syphilis typically presents with a mucosal lesion known as a chancre in the genitalia, often associated with enlarged regional lymph nodes. If you biopsy the regional lymph node, the typical histological features are capsular and pericapsular fibrosis. The lymphoid follicles are hyperplastic, and the interfollicular region may contain numerous plasma cells. Within the fibrous nodal capsule and outside the capsule, you may see features of endarteritis obliterans, featuring blood vessels with thickened walls, obliterated lumens, and perivascular plasma cells. Rarely, non-caseating granulomas may also be seen, and histochemical stains may identify spirochetes in the blood vessel walls. The nodal capsule is thickened and fibrotic, with aggregates of plasma cells around blood vessels. The lymphoid follicles display hyperplastic germinal centers, and increased plasma cells are seen in the interfollicular region, although they are not discernible at this magnification. Once again, we see the hyperplastic germinal centers, aggregates of perivascular plasma cells with stromal fibrosis, and increased plasma cells in the interfollicular region. Thank you very much for your attention.